Good afternoon. I think it's time to begin now. So my name is Sophia Brown. I'm a clinician involved in migrant care in the south of Paris area. I also study health of HIV-infected migrants living in France in French cohorts on HIV infection. And I will be moderating this session with my co-chair, Myriam Dieleman, who is a social researcher in HIV prevention in Belgium and who particularly studied life trajectories of people living with HIV. So, the topic of this session is HIV in migrant communities. Indeed, research on HIV-infected migrants is important because, as you know, this population is highly at risk for HIV. Contrary to what we were thinking for a long time, they are not only infected in their country of origin, but also frequently infected after arrival to the host country. They have to deal with a social, a cultural, and a healthcare system they do not know, with possibly language barriers, racial discrimination, stigmatization due to HIV, and poverty, which prevent them to take time for their health. In lots of countries, we are afraid that laws could be more restrictive. If we want to attain the 1990 UNAIDS objectives for 2020 or the 95 UNAIDS objective for 2030, more research and more public health actions are needed toward this population to diagnose their HIV infection as soon as possible, to connect them rapidly to the healthcare system, to treat them, to help them to take their treatment correctly, and to help them to stay in the healthcare system, so that the transmission rate can be reduced as much as possible. For that, we need to understand what rights they have, what sort of life they have, and how and why they take sexual risks, which could lead to HIV infection. Last, we have to understand what is the best way to make them having durable biological response to treatment. Before introducing each speaker, I would like to remind our speakers that time is short, only 10 minutes. So could you kindly respect this time? For the audience, please keep your questions until the end of all presentations. So now, I would like to introduce Caroline Isambert, who is going to speak on rights violations currently experienced by HIV-infected people. Caroline is an activist at the AIDS Association, the French militant association of HIV-infected and HIV-uninfected people, all of them promoting since the beginning of the HIV epidemic access to HIV testing, HIV care, HIV treatment, and now HIV prevention for all people. Within the recent context of reforms of laws on access to the healthcare system and on the legal rights for sick foreigners to stay in France, Caroline has been particularly involved in promoting access to medical care in France to HIV-infected people, particularly to migrants infected with HIV. So it's over to you, Caroline.
Thank you. First of all, I would like to thank the scientific committee for giving us the opportunity to make this oral presentation. Fundamental rights of migrants have been increasingly undermining over the last 30 years by a novelized security-minded approach towards migration policies, which are then presented as a response to the economic crisis. But what is the connection with the fight against AIDS? Why I'm speaking to you today about violations in human rights about migrants. Migrants remain disproportionately affected by HIV in EU. People born outside of the reporting country account for 37% of all newly diagnosed cases in EU. When refugees and foreigners are victims of social and legal exclusion in their host country, they become more vulnerable to HIV infection. Legal and administrative problems directly impact social and emotional security. Individuals are isolated and even marginalized which expose them to greater risk and increases the chances of infection. This situation is worsened by inadequate access to testing services, to HIV healthcare, fear of stigma, and the threat of deportation. The idea of this presentation is to counter the myth that upholding fundamental human rights and preserving public health are incompatible. So, as subjects, we take a closer look at 3 fundamental rights in the context of fight against AIDS. What happened? First example, the right to integrity of the person. What happens in the case of testing? HIV testing is of individual and collective benefit. It is important to expand testing offers, multiply them, target them better, and offer them regularly. But the temptation is strong for countries to impose testing on most at-risk populations. Greece, for instance, is moving in this direction. Against the background of a serious economic crisis, they experienced a dramatic increase in HIV prevalence. In April 2012, the Health Regulation 39A implemented compulsory testing for hepatitis, HIV, and other STIs. Those who have a positive result or are suspected of having a positive result can be held by the police. Not surprisingly, the following groups are particularly targeted: prostitutes, or those who are presumed to be migrants and drug users. What we are dealing with is a witch hunt. Dozens of migrants, women, are tested by force and are detained for several months on the sole charge of being HIV positive. The media broadcast their photographs and name and present them as time bombs. This compulsory testing regulation remained in force until 2015. It was repealed after 3 years of objections from various Greek progressive trends, pressure from international organizations, and condemnation by UNAIDS. On the one hand, this measure violates the fundamental rights to dignity, respect for private life, and the integrity of the person. On the other hand, it is completely counterproductive in terms of public health, as it creates disturbance towards health authorities. Second example, the prohibition of inhuman and degrading treatment and protection against the removal of seriously ill migrants. HIV-positive individuals' human rights will only be acknowledged when universal access to treatment has been achieved. Nevertheless, as long as this objective has not been met, we are still have an emergency. HIV-positive individuals who reside in countries where treatment is available should not be deported to countries where treatment is not available, as it will mean compromising the continuity and quality of a treatment. In the worst-case scenario, it will basically condemn them to certain death. The European Court of Human Rights has, on several occasions, made decisions about removing people living with HIV to countries where effective access to care is not guaranteed. It has to say if the removal constitutes inhuman or degrading treatment, which is prohibited by Article 3 of the European Convention on Human Rights. For a long time, the court held a particularly restrictive position, requiring a very high threshold of gravity, a real risk of dying in particularly painful circumstances. But recently, the court changed its position. The case of Mr. Paposhvili from Georgia, who arrived in Belgrade in 1998. He was suffering from chronic leukemia as well as HIV and TB. He was unable to obtain asylum or resident permit for exceptional reasons. This time, the court decided that there was inhuman or degrading treatment when the removal would expose him to a rapid and irreversible decline in his health, with a high risk of significantly reducing his life expectancy or leaving him exposed to intense suffering resulting from the lack of treatment. What we can learn from this situation is that it's worth persevering, that legal tools can be adapted and should be used to promote their application. Third example, the right to private and family life, and hence the right to a resident permit for medical reasons. For foreign people in poor health, France has a specific protection, but France is not an example for hosting the migrant, by the way. In 1997, an intense mobilization gave rise to a new law aiming to protect sick foreigners from being deported. And the following year, France provided specific resident permits for immigrants in poor health. To be entitled to this resident permit, the person must meet some strict requirements. First, the person must reside in France. Second, the person is suffering for a serious illness and needs medical care. This could include HIV, psychological disorder, or cancer. Third condition, access to health care is not guaranteed in the country of origin. For 15 years, the French experience has proven its efficiency. Thus, it does not cause a rise in the number of migrants coming into the country. Today, around 32,000 foreigners benefit from these resident permits. This only represents 0.9% of the 3.7 million foreigners living in France. This figure has remained stable for years now. It does not generate therapeutic migration. Indeed, studies like Parcours have estimated that more than the majority of sick foreigners discover that HIV, HCV, or HBV diagnosis after arriving in France. When these resident permits for health reasons is fully respected, it enables foreigners to stay in France legally, to take care of themselves and those around them, to stay in care, to be compliant to medication, and therefore less infection. The French system must be defended. It combines respect for fundamental human rights and public health objectives. In Europe, we have legal tools to protect fundamental rights for migrants. These tools are probably not widely known and can be threatened by unfavorable public opinion or a context where terrorism fosters xenophobic attack. It is now up to us, organizations, doctors, researchers, to rally together and make these rights known so they are not only acknowledged but respected and used to help end HIV. Thank you for your attention.
Thank you. So now it's my pleasure to introduce Annabelle Desgrédelou, who is going to develop the point of hardship on sexual risk and HIV infection among sub-Saharan migrants living in France. Annabelle is Research Director at the French Research Institute for Development. She's a demographer involved in social and public health research, both in France and in the Ivory Coast. She was the lead researcher of an ambitious cross-sectional investigation in France in 2012-2013, the Parcours study in migrants originating from sub-Saharan Africa and living in France, in Paris area. The objective of this study is to assess migrants' health needs and to improve strategies of prevention, screening and care for HIV and hepatitis B infection. Thank you, Annabelle.
Thanks very much for inviting me. So I don't know if it's conflict of interest, but you know everything. So in France, sub-Saharan immigrants represent around 1 million of persons, and they live in social and economic conditions generally poor, because according to the census, Nearly 42% of them are living below the poverty line, compared with 11% of persons in a household where there is no immigrants. They are also disproportionately affected by the HIV epidemic, as you know. 1 in 3 new HIV diagnoses in France concerns a person born in a sub-Saharan country. And they are also heavily touched by chronic hepatitis B. And virological data, we had virological data which suggested that a fourth of HIV infection among these immigrants might have occurred in France, but before the Parcours study, we did not have more precise estimation of HIV acquisition in France in this population. And in this presentation, we propose first an estimation of this proportion of sub-Saharan African migrants who acquired HIV infection in France or after their arrival in France, using a combination of life event and clinical data. And secondly, we try to identify social conditions that expose these immigrants to the risk of HIV infection in France. And for that, we use Parcours survey data. Parcours is this survey conducted in 2012-2013 in Paris area, Great Paris area, it's Île-de-France. And we conducted the survey among 3 groups of migrants from sub-Saharan Africa, randomly recruited in healthcare centers. 1 group in care for HIV infection, 1 group in care for hepatitis B infection, and 1 reference group with no hepatitis B and no HIV, recruited among general practitioners. And for each person, we collected data on the whole lifespan with what we call a life event questionnaire. And we collected also biological data from medical records. And so here is the methods. We assumed that HIV infection had probably been acquired in France if at least one of the following life event criteria was met. First, it's HIV diagnosis at least 11 years after arrival in France. Second, at least 1 negative HIV test in France. And third, first sex after arrival in France. And if none of these criteria was met, we estimated the duration from HIV infection to first CD4 count using a modeling of CD4 count cell decline. And in order to explore the factors of HIV infection risk in France, we analyzed the history of casual, transactional, and concurrent sexual partnerships and the history of paid sex after arrival in France, and we measured the association between these indicators and living conditions in France each year, and also the association with the characteristics of migration, age at arrival, reason of migration, time in France, and we adjusted on individual characteristic and on HIV status. So here are the results. Our study population came mostly from Western and Central Africa, and median duration of residence in France was around 12 years. And among this population, so randomly recruited, experiences of social vulnerabilities were very frequent after arrival in France. We estimated that 1 in 2 people had at least 1 year without resident permit. 1 in 3 had at least 1 year without stable housing. And in red, our estimation of acquisition of HIV post-migration, we estimated that 35% if we apply a very strict hypothesis in the CD4 modeling, and 49% if we apply a median hypothesis for the CD4 modeling, had acquired their HIV infection after arrival in France among the HIV group. Sexual partnership in France that may expose to HIV risk in France were quite frequent, as you see for men on this figure. And here is the figure for the women. So they were more frequent in men at the left than in women at the right. And moreover, you can see that they were more frequent in the group who acquired HIV after arrival in France for both sexes. So it's the first group, HIV FR. The factors here are the factors related to the probability of having had occasional partnerships at the left and transactional partnerships at the right in France for the women after adjustment. So we are going to read this together. The reference categories are represented by a point on the colored line, and when the point is at the right of the colored line, it corresponds to an odds ratio higher than 1, which means a higher probability of at-risk sexual partnership. So you can see first that HIV infection is related to occasional and transactional partnerships among women after adjustment. And after that, you can see that women who came in France because they were threatened in their country had a greater probability to have occasional and transactional partnership. And these probabilities were higher during the years without stable housing or when women were housed by family or friends. And lastly, these probabilities were higher during the years they had no residence permit. And for the men, the results are similar. Here are the factors related to the probability of having had occasional and concurrent partnership in France for men. So these probabilities were higher in the group who had acquired HIV in France after adjustment. They were higher for men living in workers' hostel or housed by association. And having no residence permit increased the probability of occasional partnership, but it decreased, as you can see on the left, on the right, the probability of concurrent partnership. And this underlines that men who are well settled in France are more concerned by concurrent partnership than men in hardship and are also exposed to HIV infection. So as a conclusion, our study revealed that almost half of sub-Saharan African migrants living with HIV in France may have acquired their HIV after their arrival in France. So we really need to improve prevention and focused prevention in this population. And second, the lack of stable housing and the lack of stable residence permits increase the probability of at-risk sexual partnerships in France. So we can conclude that hardship is a distant factor of HIV in France, HIV infection in France among these migrants. And this is especially true for women lacking housing, and a special attention should be paid to women who escaped their country because of threats, because for these women in all our study, all the indicators at the red. Lastly, I want to acknowledge all my co-authors because Parcours is a big team. My co-authors, the Parcours Study Group, and our founders, the ANRS. Just to tell you that we have just published a book in French with all the results of the study, because there is many more results as those I presented just now. We hope we are going to edit it in English next year. And you can find, if you're interested in the study, many other results in the poster presentations, Monday, Tuesday, Wednesday, in the conference. Thank you for your attention.
Thank you. The next speaker, Dr. Lynn Metropolis, is an associate professor at the Columbia University School of Social Work in the US. She has conducted extensive research related to how trauma outcomes vary across cultural contexts and the association with HIV risk behavior. She has conducted studies on migrants-related stressors, potentially traumatic events, and HIV risk behavior among labor migrants from low and middle-income countries. She also led research projects in Zambia examining the relationship between trauma, mental health, substance use, and HIV risk among labor migrants. So she is going to share her experience with us now. Thank you.
Thank you so much for having me. So I will also just disclose I have no conflict of interest. I'd like to start this presentation by just sharing with you a conceptual model which shows the pathway between potentially traumatic events and HIV infection or HIV risk behavior. And so in this pathway has been actually established, and there's been a lot of evidence that's shown that this pathway among multiple populations and Western settings. So showing that when people experience potentially traumatic events, you're at risk for trauma symptoms as well as drug and alcohol use, potentially leading to HIV risk behavior, potentially leading to HIV infection. However, this relationship is unknown among labor migrants, specifically from low and middle income countries. And this is really important to explore if this relationship exists, as we know that labor migrants from low and middle income countries are a key affected population at risk for HIV. We also know that labor migrants, specifically from low and middle income countries, have jobs which have been termed 3D jobs, so dangerous, difficult, and demeaning. So really understanding this relationship has implications for the spread of HIV, not only within the country of origin, but with countries outside of the country as well. So for today, what I'd like to do is focus on Zambia and the work that I have done there with 2 labor migrant populations. And as you can see, Zambia is a landlocked country. It is the second producer of copper in Southern Africa. There are also many rivers and lakes in the country, although it is landlocked. So there are many trucking routes throughout the country, as well as the fishing industry is an industry where over 300,000 people rely on for employment. So I'm going to be sharing with you a study that I've done with male truck drivers in Zambia. And so to start out by just kind of giving the context, there have been no epidemiological studies that have looked at the prevalence rate of HIV specifically in Zambia, but we know in Southern Africa that the rates range anywhere from 17% to 56% among truckers. In terms of female fish traders, the fishing industry or the fishing community is a highly gendered occupation where males are the fishermen and females are the fish traders. And so females will travel very long distances to go to the rivers and lakes and buy fish from the fishermen, dry it out, process it, and then travel very long distances to go and sell it. There's also a phenomenon within Zambia as well as other Southern African countries where there is the exchange of sex for fish. And so fishermen will say to a fish trader, yes, you can buy this fish from me, but I'll give you more fish. If you have sex with me, I'll give you even more fish if we don't use a condom. And so some of the prevalence rates have shown that within fishing communities, that the prevalence rates are 4 to 14 times higher within national prevalence rates, which is already high within Zambia at 13%. So the 2 studies that I'm going to share with you are 2 qualitative studies using semi-structured interviews with male truck drivers, as well as semi-structured interviews with female fish traders in Zambia, and in addition to a focus group with the female fish traders. Our primary aims were to determine what are the actual labor migrant-related stressors, what are subsequent psychosocial problems that labor migrants have, and what are HIV risk behaviors experienced among the labor migrants in Zambia. And then, in turn, to look at what is this actual relationship, and can we substantiate the conceptual model that I presented earlier. So just briefly, in terms of the demographics for the male truck drivers, one thing that I will highlight is that 10 out of the 15 truckers that we interviewed said that they engaged with sex workers or migrant women, particularly on their route or at the borders. And all of the truck drivers really talked about how it was a right that they had. And a lot of them said to some of the interviewers, it's actually very difficult. I mean, you try being away from your partner, your main partner, for a significant amount of time, and our bodies just won't allow us to not engage in sex along our route. And here you see just the demographics for the female fish traders that we interviewed. Just some of the things that I will highlight is that it was interesting that there were a number of widows within the study sample, and these weren't particularly older women, and so many of them had lost their husbands to HIV and AIDS. There also was a lower education among the female fish traders, as this was this is an occupation that's very easy to get into, takes very little skill and education. In addition, when we asked the female fish traders about exchanging sex for fish, all of them across the board said, yes, it's something that you have to engage in order to do this job. However, all of them, with the exception of one or two, said, it's not something that I do, but it's something that you have to do for the job. So it seemed that there was a lot of stigma and shame surrounding this. So in terms of looking at what are the actual psychosocial problems, what are some of the migrant-related stressors that the truck drivers dealt with? Overwhelmingly, the truckers talked about how it was very difficult to actually resist temptation at the border, and how it was very difficult that you can see here the very long queue waiting to pass through the border. So a lot of the truckers you have to wait at the borders for days. And so really just having to resist that temptation. The exposure of trucking accidents, being considered cheap labor and being a foreigner, and seeing their friends die of AIDS. So in terms of the female fish traders, again, all of them talked about the stressor of having to exchange sex for fish, and also mentioned sexual violence, intimate partner violence, which are some of the things that we expected. Unexpectedly is that female fish traders really talked about the environment as being very, very stressful. And so one of the female fish traders said, life at the river is a living hell. They talked about being exposed to road accidents, witnessing their friends drowned in the lake. Also talked about the lack of social support within the female fishing community because there was such competition to get the fish. And also talked about just the lack of services in the remote fishing camps. So bringing us back to this conceptual model, some of the things so we were also interested in are what are some of the psychosocial problems, what are some of the psychosocial outcomes that both of these labor migrants have. And so for the truck drivers, overwhelmingly, the truckers talked about an extreme fear of getting tested for HIV. And they talked about an actual avoidance of just not wanting to know what their status was. They also talked about having symptoms of grief, loneliness, and just generally feeling low. Conversely, female fish traders talked about symptoms that were very much in line with Western conceptualizations of mental health. So symptoms of post-traumatic stress disorder, anxiety, depression, having symptoms like nightmares, suicidal thoughts, widespread alcohol use, flashbacks. They also mentioned Zambian idioms of distress. And so a lot of issues that were related to the heart. So having troubles in the heart, hatred in the heart, having anger in the heart, also the symptom of thinking too much. So kind of tying this together and seeing did this provide support for this conceptual model and this relationship increasing HIV risk? I would just like to read to you a couple of the quotes that we got from the truck drivers as well as the female fish traders. So one of the truckers said, "Loneliness took a bigger part of me, and this can lead someone to start having other ideas or other sexual relationships." In terms of getting HIV tested, another trucker said, no, I have never and I can never get HIV tested. I'm very afraid, I'm dead scared. My heart is scared and I don't even want to hear about it. And another said, I'm not ready for VCT because I don't want to fall into depression. And then kind of looking at the female fish traders and whether this relationship was substantiated, one of the female fish traders said, "Women get involved in extramarital affairs because family members don't give them support. Some are orphans, others are widows and divorcees. These people are vulnerable and have nowhere where they can get help or support." Another woman said, "Women have demons that compel them to drink beer and to have more sexual partners. To avoid worries, it's better to have more sexual partners. Others drink to avoid loneliness." So tying this together, what do these, looking at these two labor migrant populations, what does this kind of tell us moving forward? It really showed that there is a complex relationship, and that there's really a need for interventions that are trauma-informed, but that also address the specific contextual needs of each of these populations. So for truckers, there was really the sexual risk behavior that they were engaging in, which was increasing their avoidance in terms of needing to get tested. For female fish traders, really being able to address stigma and shame related to exchanging sex for fish, being able to reduce trauma symptoms, and increasing services within the community. So more research is definitely needed to disentangle the pathways of this relationship. Thank you.
So now we will welcome and hear and listen to Valérie Delpech. Maybe you can come with us. So Valérie Delpech is a medical epidemiologist. She's working at Public Health England, and she's leading a team of scientists and data managers to monitor the HIV epidemic and quality of care for people living with HIV in the United Kingdom, of course. That's all? Enough?
That's good. That's it. Fantastic. Thank you very much. Slightly different title to what you've got, because I couldn't actually understand what my title was. But how I understood what I was going to talk about today. So I guess one of the points to say is it's really good to hear some of the very local concerns and obviously the psychosocial context to migration. I'm going to step right up and talk at a national level what we do about better understanding transmission of HIV among migrant populations. I've got a lot of slides. I thought I was going to do a whole symposium. No, I actually think a lot of the slides will be available, I'm hoping, so some of those slides are just for you for reference, so I won't go through it all. The United Kingdom is by and large, a more tolerant society than many others. However, it's far from perfect, and in fact, we've got quite a few issues with regards to migration, like many other parts of Europe. But we do have, as many of you know, open access to high-quality HIV testing and treatment through the NHS. And these are the facts with regards to HIV in the UK, and we're doing very well in terms of our continuum of care cascade. Nevertheless, we have a lot of people who present late each year. And we've had a lot of scaling up of testing over the last few years, particularly in our STI clinics. However, we've probably not done as well as we would like to do in targeting our particularly Black African communities and our heterosexuals who require testing. And to address that, we've had a number of initiatives of self-sampling, and there was a session this morning if you heard about that, and also we've got legal self-testing as well. So migrant populations. Well, what is a migrant? Obviously, we won't even go through the definition, except that there isn't really a perfect one. And when it comes to trying to understand migration patterns, if you like, of HIV in the UK, we can use ethnicity, we can use country of birth, time since living in the UK are also sort of proxies. But of course, there's a whole range of other factors. I'm a migrant. I was born in Chad. I lived in France. I then lived in Australia, and now I've been in the UK. Clearly, because I have a good English comprehension, I'm a completely different migrant to others who have a language issue. I also come from a system in Australia that is not that different to the healthcare system, with some differences, and that is not the situation for so many migrants who come to the UK. So navigating, as we've talked about, around the healthcare system is probably one of the big challenges for migrant populations. And then we've had this, and I'm very guilty of this because I head up the national surveillance, of splitting the world into gay, bisexual men, men who have sex with men, and then Black African, as though they were completely different worlds, and of course they're not. And then because we have a very large Black African community living with HIV compared to other ethnic groups, we tend to not even talk about the others as though they're not there. In fact, we know that's not the case. And generally, migration data, not just for people living with HIV, is actually quite poor. So it's very difficult to keep track of the size of the population, therefore have intelligent estimates of prevalence for those populations. So I tend to now think about when we all talk about migrant, we are basically saying about the other, anything that doesn't affect me. And I think Nigel Farage probably has that view, as you can see. Clearly, there are many gaps at the European level, and we're part of that we don't have. And these are data from the ECDC showing major gaps in HIV testing in migrant populations. And I'd say the UK is still in that group as well. Okay, this is quite busy, but it's quite interesting. What I've done there is our late diagnosis, which I said is about, for gay men, it's about 35%, and that's the left. And we've split that up by ethnicity and below by UK born or born in other places, and then for heterosexual men and women. And they account for altogether about 50% of our 6,000 new diagnoses a year. And you can see here what's very interesting is how diverse the population. So gay and bisexual men, 3/4 are white, but actually only 2/3 are born in the UK. So we've got a very large reach of men. Many of those men are actually HIV negative when they arrive in the UK. So it's a country they come to be openly gay and often come and confront HIV when they come to the UK. And then you've got very, very many, and this is only a summary, many different nationalities. And over time, even though there might be a few hundred each year, there are actually large populations of people living with HIV from diverse cultures and background. And of course, some of the issues picked up at the European level for why people are presenting late are not that different in the UK to what's presented here again from the Dublin Declaration. So how do we understand transmission? There's lots of different ways that we use data to understand transmission. How do they apply to migrants is what I just wanted to focus on just a little bit now. Just checking the time, how I'm going for time. We've got a number of routinely collected data, and so we've tried to capitalise on those, and in a sense they are top line, if you like, not detailed data as presented from the French study just now, Parcours, which sounds phenomenally good. But they give you a sense of the proportion of migrants or people born abroad, in this case, who may have acquired their infection in the UK. And for that, we use a CD4 back calculation and the time of arrival. It's a crude method, and it certainly wouldn't be done at an individual level. It shouldn't be done by a clinician on a one-to-one, but at population level, those estimates start to become quite important and relevant. And why do we want to know? Because we want to obviously target appropriate prevention messages to those populations. So apart from new diagnoses and CD4 back calculations, we also have modelling for the undiagnosed, and we use a number of models. And then we've also had some work looking at subtypes and molecular work that's underway. And of course, there are some behavioural data as well. I won't go through much of that, but just to say there are a number of references there. We do very well with our cascade of care. And actually, when you look at it from the point of view of inequalities across risk exposure, of which the majority of migrants fall into the heterosexual, there are no differences in the end of viral suppression. So we're doing something right when people are within the UK. However, an undiagnosed fraction still remains high, and particularly among heterosexual men and women at around 16-13%. They're not very high numbers, though. You're still looking at 16% of 19,000, so it's a few thousand people, and it becomes quite tricky. How do you implement testing strategies that really target those individuals? Half of them would be UK-born heterosexual, and the other half may be migrants who've just been here only a short time. So the targeting of testing is quite tricky. And these are our new diagnoses, and as you can see, we've been having a large decline in heterosexual contact, and that's because of migration patterns changing over the last 10 years. And that's been mostly among women, as you can see, and mostly from sub-Saharan Africa, declining among black African women there. And so now when we look at our new diagnoses and we split that up by born abroad, you can see that the born abroad's declined over time, and so now it's about 50-50 of people diagnosed each year are born in the UK versus not. And if you do that by region of birth, you can see over time that the UK is getting bigger, the light blue, but we've got quite a diverse range of people being diagnosed from many different countries, and how to capture that more appropriately is what we need to look at. And so when you use that CD4 back calculation, you can see that actually the proportion of individuals that we think from those groups were actually who were born abroad, who actually acquired their infection in the UK, has actually changed over time. Is quite different across populations, but it's around 50% almost if you take the African, which are the largest group. So really there's a lot of prevention efforts that need to go on in reducing UK-acquired infection in all groups, not just gay men. And we do that by showing a wide number of trends over time. Again, these are available in annual reports and to show you. The Maisha is a community survey. This is a very latest results. I don't even know if I'm allowed to show these, so of course you'll take photos. 50% in this survey, just conducted over the last few months, analysed over the last few months and conducted last year, were in London. It's a cross-sectional survey targeting mostly Black Africans, and there's also a salivary test to look at prevalence of HIV. And there, what's interesting is the number of condomless acts per last act at around 1 in 10%, 1 in 10, and high rates of STIs and very, very poor knowledge of PrEP. And overall in this survey, you can see the level of testing was probably improving since the last Maisha, which is over 10 years ago, but still when we compare that to our gay men, much too low the rates of HIV testing. And we're not quite sure whether we should be pushing for an annual policy of testing in African communities. It probably isn't necessary for most, but it's how do you engage communities who are not used to testing, and that's been the issue. Certainly our testing guidelines are inviting testing a lot more through general practice, which is where a lot of women in particular are likely to be picked up in addition to antenatal setting. Now, please read this and report back. No, okay, only kidding. This is our post-migration acquisition of HIV that we've looked at in terms of a model, and looking at a stochastic model there with our colleagues at University College London, which actually, forget that one, that's the systematic model there. And that was showing, by using data from the UK, epidemiological data, but also prevalence rates of HIV in their home country before coming, we estimated what could be the incidence and the prevalence of heterosexual and Black Africans. And this is quite close to the data that we are actually witnessing in our surveillance system, because the CD4 back calculation is a difficult thing to apply to individuals who don't acquire their infection within the UK. So how do you incorporate potentially understanding the whole epidemic when people might have acquired their infection abroad? So this model I've just put there for reference. You may be wanting to look at it. Other work we've been looking at are trying to understand subtypes in this case, and we've certainly seen, as you can see on the left and right, very small but a low but a present source of subtype B, which normally wouldn't have been seen in migrant populations over time. So that's something we can monitor, and certainly in France I've seen that to be higher in the past. So what next? Certainly these are estimates for gay men, which uses a CD4 back calculation. We'd like to be able to do that for all groups and not just gay men on an annual basis, and that's really understanding how we can incorporate infections prior to arrival in the UK. There's this concept of transmissibility ratio and how many people are able to transmit virus by adding the number of people who are not on treatment but in care, on treatment but not virally suppressed, as well as the estimated undiagnosed, and following that over time. And there we've got 3 examples where we've seen a steep fall in new diagnoses in other parts of London and outside London, and using that as well as a denominator of high risk to provide a transmissibility ratio here would tell us, rather than using community viral load, if you like, this would tell us how well we're doing in reducing the potential transmissibility of the virus in this community setting compared to the high-risk individuals, which are, in this particular example, people who've had a previous STI. So these are some of the ideas I just wanted to put out there so you're thinking. So some of the take-home messages, we're certainly seeing a downturn in new diagnoses in the UK, which I didn't go into here, but this is huge for us, but it's very much in gay and bisexual men at the moment. What we need to do is do exactly the same for other communities. Calling them just migrants is far too simple. They are very complex and obviously very diverse communities, and there's different ways that we can engage them, including community testing and at-home tests, etc. But also ways to monitor that over time requires very, very detailed incidence estimates and prevalence, which we're working on quite closely. Thank you very much, and sorry for the world trail.
So now we welcome our last speaker, Julia Delamo. She's a professor of research in biomedical science in the National Center for Epidemiology in Madrid, Institute of Health Carlos III in Madrid, Spain. So she will share with us her experience in researching around inequalities in HIV infection, and she has a particular interest in inequalities related to race, ethnicity, and migrant status.
Thank you, Miriam. Good afternoon, everybody, and thank you for the opportunity to contribute to this symposium. I'll be addressing access and response to ART among migrants, and these are my disclosures. I'll be addressing ART entitlement, access, ART responses, separating between virological, immunological, and very briefly touch upon mortality. And I'll be doing this in migrants in Europe, as this is my area of expertise, and because the contribution of migrant populations to the overall HIV epidemics is the highest in the European region worldwide. You're well aware, Valerie has mentioned, that migrants are very heterogeneous key populations to address. They have very different migration drivers and very different risk contexts to acquire HIV. You're also aware that these are the objectives we are all fighting for, but these 90-90-90 targets for migrant population in Europe is very hard to reach with our current policies. For some migrant groups, particularly the undocumented, some of the barriers to access testing and treatment are just gigantic. We're not there. These are slides provided by Timur Nouri, my colleague from ECDC, with whom I had the pleasure to collaborate for a number of years. And the ECDC is good at saying, know your epidemic, know your response. I will not be addressing here epidemiological figures, but I'll be presenting some data from the Dublin Declaration, which is a document that monitors the response to HIV across Europe and has lately focused on the response for migrant populations. 55 countries respond to the Dublin Declaration, and in 2014, the countries in red in this map did not provide ART to undocumented migrants, so no universal ART in Europe in 2014, in spite of all the declarations we claim that there's universal access to treatment. These are countries in red, and in 2016, some countries which were previously in red, such as Switzerland, have now granted universal access that includes undocumented migrants, but some others, like Norway, have withdrawn that entitlement. The reasons why some countries decide to withdraw access and entitlement to undocumented migrants is unknown to me. And all of this happens in spite of renewed commitment and declaration by the European Union in collaboration with ECDC. This is an example of the Maltese EU presidency earlier on this year, where a big declaration was made that we need to provide universal treatment for everybody, and they highlighted including undocumented migrants. And all of this is happening also in spite of very solid scientific evidence, such as the one compiled in this review by Jessica de Blonde and Timur Nouri, highlighting how restricting access to ART for undocumented migrants in Europe is a bottleneck to control the HIV epidemic. So we've got the evidence, apparently we've got the political will, at Central European level, let's say, but member states are just not implementing it. For people who are entitled to ART, barriers are still there. Entitlement is the first entry door, but there are many other barriers located, as you may imagine, at structural healthcare and community levels, and these barriers are of very complex nature, from the well-known socioeconomic inequalities to other legal barriers, the stigma and discrimination faced by this community, cultural and linguistic, a very, very strong gender axis that needs to be addressed and is not always properly done, as well as the psychological barrier of low-risk perceptions. All of these barriers act in synergy, and they limit access to testing, to treatment, uptake, and to optimal responses, and ultimately they undermine the public health approaches 1990, so we're not really doing very well. So it's not surprising that migrants are diagnosed later than non-migrants after what I have just told you. These are data from ECDC, the surveillance in Europe, looking at late HIV presentation according to geographical origin. And I'm highlighting in red here the very high proportion of late presentation in migrants from sub-Saharan Africa, the largest migrant group in Europe. 61% of migrants from sub-Saharan Africa diagnosed with HIV in 2015 were late diagnoses. This is a big failure. And the equal prevalence in migrants from South and Southern Asia, although numbers, as you can see, are much lower. Not all migrants do worse than native populations, and highlighting in green here, you can see how migrants originating from other Western European countries actually have lower prevalence of late diagnosis than native populations. This, again, calls back to the heterogeneity of these migrant populations. Until just in the last couple of years, ART initiation is independent from CD4 cell count values and viral load. We need to diagnose and treat everybody irrespective of their baseline CD4 cell count. But as you may imagine, if we are diagnosing migrants later than natives, it is inevitable that we will start ART in migrants later than in natives. And this is a paper published earlier on this year in AIDS in the COHERE collaboration in Eurocourt, where we looked at the timing of ART initiation in migrants, and we separated men and women, and we looked at the different geographical origins, because with a large sample size we can do these things. Migrant men, most migrant men initiated ART at lower CD4 cell counts than native men. This was so in most migrant groups, but that was particularly the case for migrants from sub-Saharan Africa and from the Caribbean. And this gap of later ART initiation was higher than natives in the group with high CD4 cell count at presentation. This we did not see in women. In women of migrant origin, CD4 cell count at initiation was relatively similar to native women, and in fact, in migrant women with higher CD4 cell counts, the likelihood of starting ART was higher than in native women. That this is probably relating to intense antenatal testing and start of ART for mother-to-child prevention. However, for the most advanced presentations, the likelihood of starting ART was lower in migrants than in natives. And in this paper also from the COHERE collaboration in Eurocode, which is in press in HIV medicine and will probably be published in the next couple of weeks, we looked at immunological and virological responses also in men and women of different migrant origins. And in this immunological response, we did these mixed models where we look at the CD4 cell count response after initiating ART. You cannot read this very well. Let's just focus on what happens in the men of different geographical origins. As you can see, all these lines before the blue arrow represent migrant men. Migrant men start ART at lower CD4 cell count, and they never catch up. So these baseline differences are maintained throughout the follow-up period, and they remain at risk of having immune deficiency for longer periods. The same happens in the women as well. And regarding viral load responses after ART initiation, well, this is what happens with men and with women, and the viral load response at different time points. Overall, viral load responses in women are poorer than in men at 12 months. Only 89% of the women had viral load suppression. It was 93% of the men. But if we looked at the different geographical origins, look at this slide. In red, we have men from sub-Saharan Africa and from the Caribbean who are well below the 90% viral load suppression target that we're aiming for. So we're also having poorer viral load responses in the largest migrant men groups. And in women, things are worse, actually. A very high number of women are below the 90% target. And look at what happens with the women from the Caribbean, where only 78% had viral load suppression at 12 months. So poorer viral load and immunological responses after ART initiation. Paradoxically, in spite of what we have seen, the mortality of migrant populations after ART initiation has been consistently shown to be better than native populations. This is work from the ART-CC collaboration, and this is just focusing on migrants in Europe after ART initiation. As you can see, compared to European natives, migrants from sub-Saharan Africa, from Asia and West, and of borderline significant in those from North America and the Middle East, had lower all-cause mortality than native populations. This has been well described, consistently described, is related to the healthy migrant effect, and this lower mortality is due to lower incidence of non-AIDS-related causes of death. Is a healthier population, the one that migrates, retains this survival advantage, but if they spend long enough in Europe, they will probably lose the survival advantage they came here with. So just to conclude, there are many things we can do to improve these major failures regarding later ART initiation and poorer immunological and virological responses in Europe. But if I had to choose just one single intervention, is the fight for universal access to ART in Europe. It's been 20 years since drugs for ART were discovered. We've been lobbying for universal access for treatment all over the world, and undocumented migrants in Europe are not entitled to ART. This is a failure for public health, for human rights, and I think it's quite frustrating to keep remembering and reminding each other that we are failing conference after conference. So with this note of really despair and a bit of frustration, I want to thank all my colleagues and the funders that have supported this work, and particularly to Inma, Susanna, and Deborah, first authors of some of the presentations I have discussed with you, and to Timur Niroy from ECDC. Thank you for your attention.